Good morning to all. I am Dr. Ashok. Today's topic is about ECG changes in myocardial infarction. The objectives of this class is, at the end of the class, you should be able to identify the ECG manifestations in patient with a non-ST elevation MI and to diagnose ST elevation MI with the help of an ECG and to localize the lesion in the coronary artery, that is the site of the coronary artery occlusion, with the help of an ECG. And we will be also discussing an overview of management of patient with an NST elevation MI and ST elevation MI. So, before going into the ECG manifestation, what is an acute coronary syndrome? So, acute coronary syndrome, it includes a group of disorders that have a common clinical presentation. That is, a patient usually present with an acute onset of an anginal pain. So, it includes three disorders. First is an ST elevation MI, second non-ST elevation MI, the third one is unstable angina. So, we need to differentiate between these three because the treatment aspect, it varies from ST elevation MI to non-ST elevation MI. So, patient with ST elevation MI can be diagnosed with the help of an ECG with the presence of an ST elevation, whereas non-ST elevation MI and unstable angina, they can be differentiated by the use of a cardiac biomarker, particularly cardiac troponin. If troponins are elevated, they come under the category of non-ST elevation MI. If troponins are normal, they come under the category of unstable angina. The most common ECG manifestation in patient with a non-ST elevation MI is ST T wave changes. So, the first one is an ST segment depression, next is an T wave inversion. Although rare, ST segment elevation, if present, will be a transient one, that is less than 20 minutes of ST segment elevation. Always remember that an initial ECG may be normal in patient with NST elevation MI in approximately 20 to 30% of the patients. So, there comes a need for a serial ECGs. If the initial ECG is normal, always remember to take a serial ECGs to identify any dynamic changes occurring over a period of time. If available, the present ECG should always be compared with the old ECG to check whether the changes that has happened is a newer one or a older one. So, what is a normal ST segment? So, the normal ST segment, it usually arises as a low amplitude wave that then merges with a larger T wave. And the polarity of the ST T wave is similar to the net polarity of the QRS complexes. So, the origin of this ST T wave, that is, this is called as a J point, and that is where one measures the elevation or depression with respect to the isoelectric point, which is a PR segment. Here is a PR segment. So, ST segment depression, there are three types of ST segment depression, and any new onset ST depression of more than 0.5 millimeter, it suggests ongoing ischemia. So, ST depression, it can be horizontal ST depression or an upsloping ST depression or a downsloping ST depression. So, this ECG picture, it depicts the various types of ST segment depression. First is an upsloping ST segment depression. So, it shows a ST segment is depressed from the baseline. You can see this is the baseline and ST segment is depressed and there is a slope ST segment elevation. So, this upsloping ST segment depression can occur as a normal phenomenon also, that is a physiological ST segment depression. So, how to differentiate between a physiological and pathological ST segment depression? By drawing a parabola. If you draw a parabola connecting these two lines, it will be a broken parabola in case of a pathological one. Whereas, if it is a physiological, it will be a continuation of this parabola. The parabola will be smooth if it is a physiological one. Here, it is a broken parabola that indicates a pathological one. The second one is a downsloping ST segment depression. So, in downsloping ST segment depression, the J point is depressed and there is a downward sloping of the ST segment present. And third one is a horizontal ST depression. So, it just depresses, there is a depression of 1 millimeter below the isoelectric baseline and there is a definitive angle between the ST T wave angle. So, this ECG, it shows the downsloping ST segment depression. So, you can see the ST segment is depressed from the J point and there is a depression that is which is facing a downward sloping of the depression. This is a downsloping ST segment depression and this ECG, it shows a horizontal ST segment depression. You can particularly see over here, over the V5 lead in the second complex, there is a horizontal ST segment depression. So, the next manifestation in patient with a non-ST elevation MI is a T wave inversion. So, T wave inversion, any deep, symmetrical and pointed T wave inversion, particularly in a lead with a prominent R wave, it indicates ischemia. Here you can see a T wave inversion in lead 1, AVL, lead 2 and in later leads V4 to V6. So, we can work out with this ECG. So, this is an ECG of a 50-year-old male with complaints of chest pain of nearly 3 hours duration. So, this ECG is a 12 lead ECG. It shows an ST segment depression in lead V4, V5, V6 and also in lead 1, lead 2 and AVL. So, you can see a more or less an upsloping ST depression here and a downsloping ST depression and a slightly horizontal ST depression over here, along with an ST elevation in AVR. So, ST depression in multiple leads along with an ST elevation in AVR, it indicates a more severe disease in patient with a non-ST elevation MI and the case early interventions. Coming to the ECG manifestations in patient with an ST elevation MI. So, how to diagnose an ST elevation MI with the help of an ECG? So, any ST segment elevation in at least 2 contiguous leads, it indicates the presence of an ST elevation MI. But in V2 and V3, there can be a normal J point or ST segment elevation which varies depending upon the age and the sex of the patient. So, any ST elevation in V2 and V3 more than 2.5 millimeter in men less than 40 years of age, or more than 2 millimeter in men more than or equal to 40 years of age, or more than 1.5 millimeter in women, it indicates a significant ST segment elevation. Whereas in all other leads, any ST elevation of more than 1 millimeter is considered to be a significant in the absence of a left ventricular hypertrophy and left bundle branch block. So, this is a usual criteria for the standard 12 lead ECG. In patient with inferior wall MI, usually there can be involvement of an right ventricular infarction or a posterior wall infarction. So, additional leads need to be taken in patient with an inferior wall MI, that is the right sided leads to identify the involvement of the RV and posterior leads to identify the posterior wall involvement. So, any ST elevation of more than 0.5 millimeter in those leads is considered to be a significant one. So, what is a contiguous lead? So, contiguous leads are nothing but leads that record the electrical activity from the same region. For example, if you want to record the electrical activity from the inferior region, the leads are lead 2, 3 and AVF. So, this forms a contiguous leads for an inferior wall MI. The same way V1 to V6 for an extensive antrovall MI and V1 to V4 are contiguous lead for anteroseptal MI, and lead 1 AVL, V5 and V6 for lateral wall MI and V6 to V9 for posterior wall MI. So, this is an ECG of a 34-year-old male with chest pain. So, it shows an ST segment elevation in V1, V2, V3 and V4, which corresponds to the, by applying the contiguous lead, it corresponds to the anteroseptal region, and 34-year-old male. So, the ST elevation should be more than or equal to 2.5 millimeter in V2 and V3. Here there is a significant ST elevation in V2 and V3 and also there is an ST elevation in V1 and V4. So, the patient fits into the criteria for a ST elevation MI. So, in general, pathologically, myocardial infarction, it results in myocardial necrosis, injury and ischemia. So, it shows the area of necrosis. This is surrounding area is the area of injury and surrounding it is the area of the ischemia. So, the necrosis, it indicates an irreversible damage to the myocardium. So, the aim of the treatment is to prevent the development of necrosed myocardium or to minimize the necrosed myocardium in post myocardial infarction. So, each of these changes, that is the necrosis, ischemia and injury, are represented in the ECG by distinct electrocardiographic manifestation. So, the area of necrosis is indicated by the QS complexes, whereas the area of injury it indicated by the ST segment, area of ischemia is indicated by the T wave inversion. So, now we can see the stages of myocardial infarction in ECG. And how does ECG evolve over a period of time in patient with an acute myocardial infarction? Usually, there are considered to be 3 stages of ECG changes. First thing is an hyperacute phase that occurs within minutes to hours after the onset of an MI. Second one is a fully evolved phase that occurs over a period of hours to days. And third one is a chronic stabilized phase, which you can see in the ECG days to weeks after a myocardial infarction. So, hyperacute phase is considered to be the earliest phase of a myocardial infarction, and it is this duration which is very critical, and treatment in this stage will produce a very good prognosis for patient with a myocardial infarction. That is why you call it as a golden hour in patient with a myocardial infarction. So, what are the ECG changes in hyperacute phase of myocardial infarction? So, hyperacute phase of myocardial infarction is characterized by tall, symmetrical, peaked and widened T waves. There will be a slope elevation of the ST segment. ST segment will normally be a slightly concave upward. Here there is a straightening of the ST segment followed by a slope elevation of the ST segment, and there is an increased amplitude of the R wave and increased ventricular activation time. That is, the time duration from the onset of the QRS to the peak of the R wave will be increased in these cases. So, this is the 12 lead ECG of the patient where it shows a tall, symmetrical, peaked and widened T waves with slope elevation of the ST segment and increased amplitude of the R wave and increased ventricular activation time. So, next ECG is the fusion of the QRS and ST wave. So, this ECG pattern is also occurs in a patient with an hyperacute, that is one of the earliest manifestation of this patient with a myocardial infarction. Here you can see, instead of this separate waves, what we have seen here, that is the R wave and ST wave and this wave. Here all this wave, it merges together. The QRS complex and the ST and T wave, they merges together and forms a single monophasic complex. This pattern is called as a tombstone ECG pattern. So, here the ECG findings are, there is an ST elevation in V1 to V6 and all the leads showing an ST elevation, and lead 1 and AVL also shows ST elevation. Lead 2, 3 and AVF, it shows ST segment depression. So, the diagnosis is an extensive anteroval MI. So, the next phase is an evolved MI that occurs over a period of hours to days after an episode of an acute myocardial infarction. So, the ECG, it shows a combination of necrosis, injury and ischemia. So, the necrosed area is shown in the ECG with the development of a new Q wave. That is, either it can be a QS complex or a capital Q small r or a small q capital R complex. Any Q wave more than 20 milliseconds in lead V1 to V4 or more than 30 milliseconds in other leads is considered to be a significant one, with the exception of in the lead 3, because in lead 3 even normally you have a small Q wave, and any Q wave more than 40 milliseconds in lead 3 with additional Q waves in lead 2 and AVF, it indicates an old myocardial infarction. There is also a decrease in R wave height and delay in the transition of this from V2 to V3. And the J point and ST segment elevation also decreases, and there is a T wave inversion. So, these are the features of an evolved myocardial infarction. So, the next stage is chronic stabilized phase. In chronic stabilized phase, usually the J point and ST elevation, they returns to baseline, and inverted T wave regains its positivity. The only manifestation is a QS complex. Any patient with an old MI, they usually have a QS complex. So, the amount of QS complex and the presence of QS complex, it depends upon how soon the myocardium has been devascularized and how much amount of myocardium has gone into the necrotic phase. So, this is an ECG of a middle-aged man with an ST elevation MI who underwent a primary PCA, and ECG has been taken 1 month after the index event. So, it shows QS complex only in lead V1, and in all other leads there is no Q waves are present, there is a small R wave is there. So, it indicates the amount of myocardium that has been necrosed during the index event is very minimal. So, next one is a localization of myocardial infarction. So, why do we need to localize myocardial infarction? One is to identify which artery has been involved, that is to identify the culprit artery in patient with a myocardial infarction. Another thing is to assess the amount of myocardium that is at risk. Say a patient having a lesion in a proximal part of a vessel which supplies a larger area of the myocardium. So, the large area of myocardium will be at risk, whereas a patient having a occlusion in a distal part of a vessel which usually supplies a small area of the myocardium. So, which indirectly gives us the prognosis of the patient with a myocardial infarction. So, the heart is supplied by two major coronary arteries. One is the left main coronary artery and right coronary artery. So, left main coronary artery divides into left anterior descending artery, which gives rise to diagonal and the septal branches, and left circumflex artery, which gives rise to obtuse marginal branch. And the second one is a right coronary artery. Right coronary artery, it has various branches. The first thing is a conus and sinoatrial branch, RV branch, acute marginal branch, AV nodal branch, and distally it divides into posterior descending artery and posterolateral branches. So, this slide shows the angiographic imaging of coronary arteries. So, this is an LAD, that is left anterior descending artery. You can see this one. So, you can see the branches. So, this branch is the septal branch, and the above one, this is a diagonal branch. So, in anteroval MI, the occlusion can occur anywhere, that is either proximal to both the branches or distal to both the branches or in between the both the branches. So, the origin of the branches here, it varies. That is, here in this case, the diagonal arises first and septal is a second branch. So, it can be a variable one. Either a septal, it comes as a first branch followed by a diagonal branch. So, therein the ECG manifestation differs depending upon the origin of the branches in patient with an anteroval MI. Next one is, this is a left circumflex artery. It gives rise to obtuse marginal branches. So, these are the obtuse marginal branches OM1 and OM2. This is the right coronary artery. Right coronary artery, the branches are, one is a conus branch and SA nodal branch. This is the RV branch, and distally it divides into posterior descending artery and posterolateral branches. So, anteroval MI, as discussed, the lesion can be either proximal to both the branches, or it can be distal to both the branches, or the lesion can be in between the branches, that in between the septal and the diagonal. There is one part will be involved, either a septal may be involved or a diagonal will be involved. So, depending on this, the ECG manifestation will also differ in patient with an anteroval MI. So, by seeing the leads wherein the ST elevation is present, you can identify the type of myocardial infarction involving the LAD. So, in case of an anteroseptal in a myocardial infarction, there is an ST elevation in V1 to V4. That is, the LAD before S1 is occluded, that is, septal vessel is involved with this occlusion, and the lesion is after the diagonal, that is, D1 arises first, followed by septal, and in between is a lesion. An anterolateral myocardial infarction which shows an ST elevation in the lateral leads, that is lead 1 AVL, and also in the anterior leads V2 to V4, there can be a reciprocal ST segment depression in lead 2, 3 and AVF. Always look for this reciprocal changes in ECG, which will give you a clue to the underlying lesion. So, here the lesion is LAD before the D1 and after the S1, that is septal branch is span. Whenever there is a septal involvement, usually you see an ST elevation predominantly in the V1. Whenever there is a diagonal involvement, the ST elevation is commonly seen in the lateral leads also. So, anteroapical is distal LAD, that is distal to both the branches. In these patients, there can be an ST elevation from V2 to V6, and there can also be a minimal amount of ST elevation in lead 2, 3 and AVF, where there is a combined ST elevation in both anterior and inferior lead, and ST segment depression in lead AVL. And in case of an extensive anteroval MI, that is because of a lesion in the proximal LAD. So, the ECG manifestations are QRBB, that is an RBB pattern with an initial Q wave, or there can be an extensive ST segment elevation from lead V1 to V6 and lead 1 and AVL with ST segment depression in lead 2, 3 and AVF. So, an isolated lateral wall MI, it can be because of an occlusion in the ramus, diagonal or obtuse marginal with ST segment elevation predominantly in the lateral leads lead 1 AVL and V5 and V6. So, the ECG pattern in proximal LAD occlusion. So, first thing is QRBB, that is an RBB with an initial Q wave. The next pattern is there is an extensive ST segment elevation from V1 to V6 and also in the lateral leads with reciprocal changes in lead 2, 3 and AVF in the form of ST segment depression. So, the ST elevation in AVL and AVR, it depends upon whether there is a predominant involvement of the lateral part, that is the diagonal involvement or the septal region. So, any ST segment depression, we have seen that whenever there is a diagonal involvement, there is an ST segment depression in the inferior lead. If that ST segment depression in lead 3 plus AVF more than or equal to 2.5 millimeter, it suggests LAD lesion is proximal to the diagonal one. And similarly, ST elevation in AVR and V1, it occurs whenever there is a septal occlusion. So, this ST elevation in AVR and V1 more than ST depression in V6, it indicates the LAD lesion is proximal to the septal branch. So, this is a 12-lead ECG taken in a patient with a 60-year-old male with complaints of chest pain of 1 hour duration. So, it shows an ST segment elevation in lead V1 to V4, and there is also a minimal elevation in the lead AVL and lead 1 and ST segment depression in lead 2, 3 and AVF. So, it is a typical QRBB pattern, that is the right bundle branch block with an initial QAs are present over here. So, QRBB pattern, it localizes the lesion to the proximal LAD. So, as discussed in proximal LAD, there will be an extensive ST segment elevation in all the lead with reciprocal ST segment depression in lead 2, 3 and AVF. So, this is what we have discussed previously in the tombstone pattern of ECG. So, we can localize it here. So, it shows an extensive ST segment elevation from V1 to V6. All the segment shows an ST segment elevation, and lead 1 and AVL also shows an ST segment elevation, whereas there is a ST depression in lead 2, lead 3 and AVF. So, ST depression in lead 2, 3 and AVF, it indicates there is a diagonal involvement along with an ST elevation in lead 1 and AVL, whereas ST elevation in V1, it indicates the septal is also involved. So, the LAD lesion is proximal to the both the branches, that is D1 and S1. Next thing is the proximal to septal branch, that is septal branch is involved, you call it as an anteroseptal MI. There will be a ST elevation in AVR and an ST elevation of more than 2.5 millimeter in V1 and ST segment depression in V6 and AVL. And the next one is a proximal to diagonal branch. There is a diagonal branches involved in the occlusion. Here you can see an ST segment elevation in the lateral leads, lead 1 AVL, V2 to V4, and there is a reciprocal ST segment depression in lead 2, 3 and AVF. So we can localize this lesion here. So this is a standard 12 lead ECG showing an ST segment elevation in V2, V3, V4, V5 and V6. And also there is an ST elevation in lead 1 and AVL with reciprocal ST depression in lead 2, lead 3 and AVF. So just look into the lead V1, there is no significant ST elevation in the lead V1. So what does it indicate? So lead V1 ST elevation, if present, it shows there is a occlusion of the septal branch. So here lead V1, there is no ST elevation is there. So probably the occlusion should have been spared. So the occlusion is present distal to the S1 branch and proximal to the D1. So D1 involvement is indicated with the help of ST elevation in lead 1 AVL and also the reciprocal changes in lead 2, 3 and AVF. So coming to the ECG pattern, distal to both the branches. So distal to both the branches, there will be an ST elevation in V2 to V6, but not predominantly in V1. In lead 2, 3 and AVF, there will be a slight ST segment elevation can be there and ST depression in lead AVL. So here comes the confusion of it. The patient with this pattern of ECG, distal LED occlusion, they have an ST elevation in anterior leads and also an ST elevation in inferior lead. Here we get confused with the lesion in right coronary artery occlusion, that is an inferior wall MI, wherein the ST elevation you see in the inferior leads, and sometimes if there is a RV involvement, you see an ST elevation in V1. So it helps to differentiate between the lesion in the proximal RCA causing that ECG pattern or an LAD lesion causing that one. So in case of a proximal RCA occlusion presenting as an inferior wall MI, if there is an ST elevation, usually it will be limited to V1 and V1 ST elevation will be more when compared to that of the ST elevation in V3 to V4. Whereas in case of LAD lesion, V3 to V4 ST elevation is more when compared to that of ST elevation in V1. And similarly, in case of an inferior wall MI, the ST elevation in inferior leads will be more when compared to that of the ST elevation in the precordial lead, that is V1 to V3. In case of an LAD lesion, the ST elevation in the inferior lead will be less when compared to that of the ST elevation in precordial lead. And coming to the reciprocal changes, there can be an ST segment depression in lead 1 and AVL. Usually there is not much of an ST depression in lead 1. So it helps in differentiating the patient who present with an ST elevation in both anterior leads and also the inferior leads. So next one is an inferior wall myocardial infarction. So inferior wall myocardial infarction, it can be due to either occlusion of a right coronary artery or a left coronary artery. So we diagnose an inferior wall myocardial infarction with the help of an ST segment elevation in leads that record the electrical activity from the inferior part of the ventricle. That is lead 2, lead 3 and AVF. If any two contiguous lead, it shows an ST segment elevation that indicates the inferior wall MI. So always remember, inferior wall MI may be associated with an involvement of the right ventricle or a posterior wall. So to identify it, we need extra leads to detect the presence of a RVMI, that is the right sided lead, and for identification of the posterior wall MI, you can take leads, that is the posterior leads, by keeping the leads over the back. So the ECG manifestations in patient with a right coronary artery occlusion. So there will be an ST elevation in lead 3 more than lead 2 and ST depression in lead 1 and AVL. So sum of ST segment depression in V2 to V3 by ST elevation in lead 2, 3 and AVF is less than 1. So it's basically the ST elevation in inferior lead should be more than the ST depression in V1 to V3 in case of a right coronary artery occlusion. And ST elevation in V1 or ST elevation in the right side oriented lead and ST depression in V3 by ST elevation in lead 3 less than 0.5 in case of a proximal RCA lesion and 0.5 to 1.2 in case of a distal RCA lesion. So we can apply this criteria to an ECG. So this is a standard 12 lead ECG taken in a patient with acute onset of the chest pain of just 30 minutes duration. So the ECG shows an ST segment elevation. ST segment elevation in lead 2, lead 3 and AVF, and there is an ST segment depression in lead V1, V2 and V3 with ST depression in lead 1 and AVL. So applying to what has been discussed previously, there is an ST elevation in lead 3 more than lead 2. In this ECG, there is an ST segment elevation in lead 3 is more than lead 2. There is an ST segment depression in lead, AVL and lead 1, and sum of the ST segment depression in V1 to V3 by sum of ST segment elevation in lead 2, 3 and AVF is less than 1. So, this part inferior lead ST elevation is more when compared to that of the ST depression in anterior lead. So, ST depression in V3 divided by ST elevation in lead 3 is less than 0.5, which indicates the location of the lesion into the proximal RCA. So, it is a case of an inferior wall MI with the lesion localized to the proximal RCA. In left circumflex artery, the ECG manifestations include ST elevation in lead 2 more than lead 3 and ST elevation sometimes in V5 and V6. There is no ST segment depression in lead 1 and AVL, and sometimes there can be an ST elevation in lead 1 and AVL. Sum of the ST segment depression in V1 to V3 by ST segment elevation in lead 2, 3 and AVF will be more than 1. So, this is just opposite to that of the right coronary artery, where the sum of ST segment depression in V1 to V3 should be more when compared to that of the ST elevation in lead 2, 3 and AVF. And ST depression in V3 by ST elevation in lead 3 more than 1.2. So, by applying this to this ECG, so this is a 12 lead ECG of a patient with an acute onset of chest pain. So, here you can see this ST segment elevation in lead 2 is more than lead 3. There is a minimal ST elevation in V5 and V6, and look at the lead 1 and AVL, there is no ST segment depression. If there is an ST segment depression, the lesion localizes to the right coronary artery, and there is an ST segment depression in V1 to V3. So, this ST segment depression in V1 to V3 is more when compared to that of the sum of the ST segment elevation in lead 2, 3 and AVF, and this ST depression in V3 by ST elevation in lead 3, it is more than 1.2. So, it localizes the lesion to the left circumflex artery. So, next thing is a posterior wall MI. So, any patient with an inferior wall MI always check for the presence of a posterior wall involvement and right-sided involvement. So, how to diagnose a posterior wall MI? It usually occurs in the context of an inferior or lateral wall MI. So, if you have a posterior lead, that is V6 to V9, you can identify it with the presence of an ST segment elevation in lead V6 to V9 of at least 0.5 millimeter or 0.05 millivolt. So, if posterior leads are not available, with the help of an anterior lead, we can identify it. Because the anterior lead, it shows a mirror image pattern of what we see in posterior leads. So, the anterior lead changes the input ST segment depression in V1 to V3 of more than 0.5 millimeter and tall and widen R wave in V1 to V3 and upright and tall T waves. So, mirror image, just if you reverse the ECG and look it from the back, it shows this pattern of this ST segment elevation, which is usually recorded in a posterior lead. So, this is the previous ECG. Here you can see there is an ST segment depression more than 0.5 millimeter in lead V1, V2 and V3, and there is a tall and upright T wave is there, which indicates the presence of a posterior wall MI, which should be confirmed by taking a posterior lead ECG. So, in the same patient, we have taken a posterior lead ECG, that is a V7, V8 and V9. It shows a significant elevation in the ST segment from V7 to V9, which indicate the presence of an posterior wall myocardial infarction. Next thing is the identification of the RV myocardial infarction. So, isolated RVMI is rare. 30% of the patient with an inferior wall MI will show evidence of an RV myocardial infarction. So, how to diagnose an RVMI? If we have a right-sided oriented lead, any ST elevation of more than 1 millimeter in V1 or from V4R to V6R, it indicates the involvement of the right ventricle, or we can identify it in the precordial leads with the presence of an ST elevation in V1 or ST elevation in V1 and ST depression in V2, which is highly specific for RV infarction, or isoelectric ST segment in V1 with marked ST depression in V2. So, this is a 12 lead ECG of a patient with complaints of chest pain of 1 hour duration. Here you can see an ST segment elevation in lead 2, 3 and AVF with ST depression in lead 1 and AVL, which puts the lesion localization into the right coronary artery, and there is also an ST elevation in V1, which indicates there is an involvement of the right ventricle. So, it is a simple flow chart which helps in localization of the patient with a inferior wall MI. So, patient with an ST elevation in lead 2, 3 and AVF, it can be either because of a right coronary artery or an LCX occlusion. So, the first thing we need to see is whether we have a right side oriented lead. If we have a right side oriented lead, look for any ST segment elevation in V4R. If it is present, it localizes the lesion to proximal RCA, that is with involvement of the right ventricular branch. If there is no ST segment elevation, look at the T waves, whether it is positive or negative. If it is positive, the lesion is localized to distal RCA, and if it is negative, the lesion is localized to left circumflex artery. If we do not have an right sided lead, Then look for ST segment elevation in lead 1, whether there is a depression, elevation or isoelectric lead 1. If there is an ST segment depression in lead 1, it indicates the lesion in the RCA. If there is an ST segment elevation in lead 1, it indicates the lesion in left circumflex artery. If it is isoelectric, we will go to the next algorithm. Whenever the lead 1 is isoelectric, look for ST segment elevation in lead 2 more than or equal to lead 3. If it is yes, the diagnosis is LCX occlusion. If it is no, then again look into the sum of this one. Sum of ST segment depression in V1 to V3 divided by ST segment elevation in lead 2-3 AVF more than 1. If it is yes, then it is LCX. If it is no, it is an right coronary artery. So, applying this criteria to this ECG, so this is a 12-lead ECG of a patient with an acute onset of chest pain. It shows an ST segment elevation in lead 2-3 AVF and ST depression in lead 1 AVL, and there is also an ST elevation in B1. We do not have a right-sided lead, so just look into the ST segment in lead 1. So, ST segment in lead 1, there is a depression which localizes the lesion to the right coronary artery. So, this is the next ECG of a 60-year-old male with complaints of chest pain of 1.5 hour duration. Here you can see an ST segment elevation in lead 2, lead 3 and AVF. There is an ST segment depression in AVL, whereas this lead 1 it shows an isoelectric ST segment. And there is also minimal ST depression in V2 and V3. So, by going with the algorithm, lead 1 it does not show an ST elevation or ST depression, it is nearly isoelectric. So, coming to the second part of algorithm, when it is isoelectric, look for ST elevation in lead 2 more than or equal to lead 3. Here in this ECG, lead 2 is not more than lead 3. So, coming to the next part, measure the ST segment depression in V1 to V3. So, some of the ST depression is around some 2 mm, whereas this ST elevation in lead 2, 3 and AVF it is around 6 mm. So, it is not more than 1 in this case. So, the localization it goes to right coronary artery. So, in the same patient we have taken a posterior leads. That is, these 3 leads are taken by placing the electrodes in the posterior part, which shows a minimal ST segment elevation of 0.5 mm in the posterior leads. That indicates there is an involvement of the posterior wall. So, in the same patient we have taken a right sided leads. So, in the right side, these 3 are the right sided leads. So, the right sided leads also shows an ST segment elevation, which localizes the lesion to the right coronary artery with involvement of the right ventricle, that is a proximal right coronary artery involvement. Coming to the management, it involves pharmacological treatment and invasive treatment. So, in the pharmacological treatment, a patient with an acute onset of pain, one is a symptomatic relief. You try to control the pain by the use of a sublingual nitrates or intravenous nitrates, or by using a morphine or beta blockers. And the next part of the treatment is antiplatelets and anticoagulation. So, anticoagulation usually enoxaparin is given according to the body weight of the patient, it can be given. And antiplatelets, you call it as a loading dose. So, loading dose aspirin should be given in a dose of 300 mg stat followed by 75 to 100 mg daily. And the other thing is either one of this thing, that is clopidogrel, ticagrelor and prasugrel. So, the doses are 300 mg of clopidogrel followed by 75 mg daily, and ticagrelor 180 mg loading followed by 90 mg twice daily, whereas the prasugrel 60 mg loading followed by 10 mg once daily. Here the prasugrel should be given only if the patient is going in for a invasive management. And just for medically managed patient, most of the patients can be put on a clopidogrel dosages. So, next part of the treatment is an invasive treatment. So, invasive coronary angiography, there are some subset of patients who require a very early invasive coronary angiogram in patient with a non-ST elevation MI. The patient having a persistent chest pain, or patient in cardiogenic shock, or patients having a refractory arrhythmias, or there is an extensive ST segment depression with ST elevation in AVR, which indicates a very severe disease. So, these subgroup of patients they require an early invasive angiogram. So, the treatment of STEMI differs, that is earlier the reperfusion, better the benefit, that is you can minimize the amount of myocardium that is going into the irreversible damage, that is the necrosed area can be minimized. Two strategies are there apart from the medical management, that is your use of the antiplatelet, anticoagulation and control of pain and hemodynamic stability of the patient by using inotropes if needed, and O2 therapy if the oxygen saturation is less than 92%. So, the early reperfusion strategies they include a primary PCI, that is directly the patient will be taken up to the cath lab and revascularization will be done. Usually as this ST elevation MI is because of 100% occlusion in the coronary artery, we will pass on a wire and balloon it and stent that part if needed. That is a primary percutaneous intervention. And if cath lab is not available or the patient is not willing for a primary PCI, you can also opt for a thrombolysis. The various drugs have been studied in the thrombolysis or tenecteplase, streptokinase and retiplase. So, earlier the treatment in patient with an ST elevation MI, the better will be the response. So, that is what the golden hour says. That is from the symptom onset, the initial 1 hour period is a golden hour and the patient should get revascularized during that period, will give a better benefit for the patient and long term prognosis will be very good in those patients. Thank you for the patient listening. So, just a take home message. So, initial ECGs can be normal in patient with a ST elevation MI or a non-ST elevation MI. So, when you have a high index of suspicion, always do a serial ECGs, because many times we miss a myocardial infarction as the initial ECG is normal and the patient will be discharged or sent out of the hospital considering it as a gastric issue. Always remember, whenever there is a typical pain, always take a serial ECGs and don't forget about that one. Okay. Thank you very much for the patient listening. Thank you.